the TX implant. So the counter, can you make the counter 1 hour 60 minutes? I will do 60 minutes, then we'll catch up. Reset it for me. So, before we finish up this afternoon, we're looking at full arch immediacy and what we're doing in Melbourne. I just want to talk about peri-implantitis because this continues with our discussion on the risk factors. So you remember there's bone loss, recession, overload, and now peri-implantitis. Is peri-implantitis a problem in this part of the world? We have problems here in Vietnam? Yeah, I think it seems to be everywhere. So let me talk about. I better time for my own watch. 2:50. Okay, so risk factors. I'll look at the treatment of peri-implantitis and how I treat it. And my treatment, I can tell you, is very simple. Nothing fancy with my treatment. I keep it very simple. And also, I'll look at some strategies to minimize the risk in periodontitis patients because we know these are the patients who are most at risk. So the first thing that we have to remember is that when someone develops peri-implantitis, it can progress very rapidly. It behaves like an aggressive periodontitis. So you see an example here of a patient. The implant was placed in April 2011. November 2011, everything's looking fine. Then 6 years later, we start to see some marginal bone loss. The dental hygienist has a look at it, but doesn't say anything to me. Oh, it doesn't look quite right. Okay, and then suddenly, from February to October 2017, it's rapidly progressed. Okay, so the one message I want to give to everybody is that with peri-implantitis, don't look at it and go, oh, maybe we'll check next time and see how it looks. You need to intervene and you need to treat it because it behaves very, very differently to other types of infections. It can progress very rapidly. And especially if you're dealing with implants that have a micro rough surface, it can go quickly. And then if you have implants with a porous surface and very rough surfaces, then it can accelerate. You know? So don't watch and wait. It requires prompt treatment. So if we look at the risk factors for peri-implantitis, we can broadly look at 2 risk factors. On the one hand, we have patient-related risk factors, and then on the other hand, I'll put down dentist risk factors. That means us making some clinical decisions that maybe increase the risk. Okay, and I'll talk a little bit about the model of disease versus the model of a complication. So patient risk factors, we know that periodontitis and peri-implantitis are essentially not too different from each other in terms of the etiology, pathogenesis, and the risk assessment. We've known this now for more than 20 years. And we know what makes people more susceptible to peri-implantitis. The difference being that because you have a rough surface and a deep pocket, which is anaerobic, the disease can progress incredibly quickly and rapidly. So what are the patient risk factors? I think the number 1 risk factor is oral hygiene or lack of oral hygiene. So there is substantial evidence showing that poor oral hygiene is associated with peri-implant disease and marginal bone loss. So the odds ratio for this is 14.3. So what does this mean? The odds ratio is what are the odds of someone developing a condition or a disease that has the risk factor compared to what the odds of another person getting the disease without the risk factor. So the disease is peri-implantitis, the factor is oral hygiene. And if the odds ratio is 1, it means they are equivalent, they have the same risk. If the odds ratio is 2, it means there's a 100% greater risk. You see here a 14.3%. That's 1,300% greater chance of developing peri-implantitis with poor oral hygiene. So I'll repeat that. Odds ratio of 14.3 means the odds are 1,330 times higher than someone who doesn't clean their teeth compared to someone who cleans their teeth. So the odds are very high. Bottom line, if your patient is not compliant, whether they're a periodontal patient or not a periodontal patient, if they show no willingness to keep their own teeth clean, don't place implants because they are a recipe for periimplantitis. You have to have your patients understand this and cooperate this. Periodontitis, we know, is a risk factor. And if you have patients with residual pockets of 6 millimeters or more, with inflammation and bleeding after probing, they have a much higher risk of developing periimplantitis. So these can be patients who you are treating, who have been treated but still have residual pockets. In other words, they still have active disease. So these patients are not good patients to have implants placed. And if you do choose to place implants on these individuals, you have to ensure that they're highly compliant, meaning they will come back for maintenance and for you or your hygienist to review the patients on a regular basis. So beware that residual untreated disease is a significant risk factor. Cigarette smoking. This used to be thought of as a very high risk, but more recent studies have lowered the risk somewhat. So the odds ratio is 1.7, meaning the 70% greater odds or greater chance that a smoker will develop periimplantitis compared to a non-smoker. I mean, it's still a significant risk, still 70% greater, but it's not as high as what was thought originally. Then we have the combination of periodontitis and smoking. So this combination exponentially increases the hazard or the risk of the patient developing periimplantitis. So this is this concept of multiple risk factors. So now you have a patient who smokes, doesn't clean their teeth, has pockets greater than 6 millimeters remaining. So each of these has a risk. Now you have multiple risks. It's very difficult to quantify what the multiple risks are, but some studies like this show that combination increases the overall risk. And then if there are periodontal patients, they must be in a supportive maintenance program. So here's a study by Costa in 2012. They took partially edentulous patients with periimplant mucositis, right? Regular supportive maintenance was in 39 patients, and those without maintenance had 41 patients. And they looked at them 5 years later. Those in regular supportive maintenance had an incidence of periimplantitis of 18%. Whereas those without maintenance from the mucositis, they went on to develop periimplantitis of 43.9%. So the data is so strong and so overwhelming for the need for supportive maintenance. So now I ask the question once again. The patient comes to see you for the first time with periodontal disease. You provide them periodontal treatment, everything goes fine. We say, right, we can go on and do implants. How do you know if the patient will come back for maintenance? Can you predict this? How many of your patients come back for their regular checkups after you finish treatment? What proportion? If you do an analysis in your practice, you'll see actually it's quite low. A lot of people do not come back after the treatment. They forget, they have excuses and other reasons. So particularly with periodontal patients, you can only tell if they're going to be a compliant patient if you have treated them for a period of time. You cannot tell after one visit, after 2 visits, after 6 months. Because basically I don't trust my patients to come back. They need to prove to me that they're going to be compliant before I will think about dental implants for them. And of course we spoke about that this morning, the other site-related factors in the periodontal patient, the lack of bone, lack of keratinized tissue, and so on. The evidence now is overwhelming for the need for good tissue, soft tissue thickness, and good soft tissue, and good zone of keratinized tissue for the patients. So here is a summary of patient-related risk factors with the odds ratios for each of them. Poor oral hygiene, the highest, 14.3. So remember, that's 1,330% higher odds. Tobacco smoking, 1.7. History of treated periodontitis. Treated, under control. We still have odds of about 3 to 4 odds ratio. Residual pockets, the odds ratio is 5. Lack of maintenance, almost 6. history of periodontitis and lack of maintenance shoots up to 11. And then the diabetic patient, 2.5. So now I have a patient who smokes, doesn't clean their teeth, has gum disease, pockets, residual pockets, doesn't want to come back for maintenance, and has diabetes. So what do you think the chances of that patient developing peri-implantitis? It's almost guaranteed. At some point over the next 3 to 5 to 8 years after you place the implant. So now I ask the next question. Who is at fault? Is it the patient because they have all these risk factors? Or is it because of you as the dentist who decides to put the implant into that patient's mouth? So we have to sometimes ask ourselves some very hard, tough questions about our approach to managing these patients and to avoid these types of complications. So I would like to just stop a little bit and maybe look at things in a slightly more philosophical way. Peri-implantitis only exists because there's a dental implant. No implant, no peri-implantitis. In other words, peri-implantitis is a man-made disease. Yes, and for a long time we have treated this as a disease. It's not natural. It's not natural because we have a piece of titanium sticking out of the patient's jaws. Okay, and if you look into the orthopedic literature, they have what is known as periprosthetic infections and complications. And they talk about things like aseptic loosening. So the implant, the hip joint has started to move in the bone. It's lost its integration. We call it overload. Right? Periprosthetic fractures. So they call it a fracture, we also call it a fracture. Then there's joint infection. They call it infection, we give it the name of a disease, peri-implantitis. So in dentistry, we treat it like a disease. In orthopedics, it's an infection. It's a complication. Right? And you just look at this sort of a review article like this. You pull up any review article on periprosthetic infections. And not once is it referred to as a disease. It's not a disease because it's an infection on the joint. Why is it in dentistry we call it a disease? I don't know. Maybe it's because all the periodontists got involved 20 years ago and decided we're going to call this a disease and treat it like a disease. Now, the one good thing about treating it like a disease is that we have made so much progress in understanding the patient-related risk factors because we are treating it like a disease. It's just like diabetes. Diabetes is a disease. So we look at risk factors, weight, exercise, genetic predisposition, and so on. Yeah? So that's where the approach is very different. It's like a physician. A little bit closer to the mouth. These are bone-anchored hearing aids placed into the skull. And a paper on complications of bone-anchored hearing aids. Proper patient selection, meticulous surgical technique, and good hygiene around the implants is the most critical aspect in minimizing complication. Does it sound familiar? So I could just change this to dental implants. We want exactly the same thing. Proper patient selection, meticulous surgical technique, and hygiene around the implants. Exactly the same. But not once do they refer to this as a disease. Never refer to it as a disease. And yet we refer to it as a disease. So we have what I call the disease model of an infection versus orthopedics, which is the complication model. Now the problem with the disease model is we attribute the etiology mainly to the patient. That's the patient's fault. It's a disease. It's the patient's fault. Remember, no implants, no disease. It's man-made. The complication model attributes the etiology both to the patient and the clinician. Because if I'm an orthopedic surgeon, I can have an error in the placement of the hip. I can have a complication at the time, right? So we have there is responsibility taken by the clinicians involved in the treatment. So while I think it's been fantastic that we looked at peri-implantitis as a disease, I think what it's done is it's made us as dentists forget that it's a complication that we actually have a lot to do with the development of peri-implantitis in our patients, because we are in the driver's seat. I'll share with you this study from Professor Danny Bruce, published in 2012. This is a 10-year paper on tissue level, and it's relevant for the next lecture. And Dr. Lam spoke about this. So the tissue level design is a wonderful design. And this is tissue level implants with an SLA surface. 10-year prospective study. Retrospective study. 303 patients with 511 implants, partially edentulous, reconstructions, not full arch. Conservative surgical approach. So the conservative surgical approach means no immediate implants, and it's early implant placement, or if it heals site, not enough bone, graft first. So this is what we call a conservative surgical approach. Very low risk. Make sure the bone is healthy before the implants are placed. So Danny, Professor Boozer, showed a 10-year survival rate of 98.8% and a 10-year success rate of 97%. Right, so this is the absence of complications. So over 10 years, only 3%, 3 out of 100 implants developed a complication. Incredibly low. I wish in my practice I would be as low as that. Right? But I do immediate implants. Sometimes we do a little bit of risky procedures to increase our chances of failure. So look at the peri-implantitis. Surviving implants. Of the surviving implants, 0.4, 2 out of all those patients had peri-implantitis at the time of examination. And 7 had a history of peri-implantitis in the 10 years before that. Overall, the prevalence of peri-implantitis is 2.8%. That's very low to what is reported in the literature. And these are not patients in maintenance. These are patients who have been treated and they go back to the general practitioners and they receive more dental care. The difference is the low-risk surgical approach to make sure that the foundation for the implant is sound, good bone and good soft tissue. So no immediate implants, GBR done to reconstruct the bone, and when necessary, stage bone grafting. So sometimes, as I said, more treatment is required to have less risk and higher predictability. I think we need to take lessons from the burn group, the oral surgical department in the burn group run by Danny Boozer, to think about how we approach surgery for our patients, and particularly those patients with the risk of peri-implantitis. So I published this chapter in the 3rd ITI treatment guide with Danny Boozer. He was doing a sabbatical in Melbourne for 6 months, and he sat down, he wrote treatment guide number 3 while he was on sabbatical. He actually worked through Christmas time. He's crazy hardworking. I don't think I could have done it. If he stayed for longer than 6 months, I would have gone crazy, because he's such a hardworking individual. But we said there are all these multiple risk factors for complications. You have the clinician, you have the patient, you have the biomaterials, you have the treatment approach. Right? So all these things factor into the complication. But guess what? The clinician assesses the patient to see whether they're a suitable patient or not. The clinician chooses the biomaterials, what implant system, what grafting materials to use. The clinician recommends the treatment approach. I never had a patient come to see me and say, Doctor, I've lost my upper molar, and I want a type 3 treatment with the transcrestal sinus flow graft for you to replace this tooth implant. Never. The patients never specify the treatment because they don't know. They trust you to provide the right recommendations. So as dentists, we are in what we say in English, we are in the driver's seat. We are driving the bus. And we make all the decisions about which direction we go, which patients to accept for treatment. And so if you take the complication model rather than the disease model, you can see that the clinician has a lot to do with the decision making and has a lot to do with the etiology of complications when they arise. So now let's look at clinician-related risk factors. So there's periodontal patients. So a periodontal patient is a patient risk factor. But if you put the implant into the patient who's not got controlled periodontitis, then you have made the decision. Now it becomes a clinician risk factor because you've made an incorrect decision. So this patient was referred to me, had implant work done overseas, no maintenance, no treatment of the gum disease, and we wonder why his mandibular implants on both sides have failed. So we've taken them all out, provided treatment, and we've done the reconstruction. It took several years to get to that stage. Placing implants into narrow ridges. So putting implants into a narrow ridge, develop inflammation, aseptic necrosis. We spoke about that this morning. Whose fault? The narrow bone is a patient risk factor, yes. But me putting the implant in, this is my case, I put this implant in. That was my decision. To try and save the patient bone graft. It didn't work. Now we have a susceptible implant sitting there. Fortunately, it's still being maintained. Yeah, but it's a clinician-related risk factor if you choose to proceed with the treatment. Peri-implantitis. Have a look at these cases of peri-implantitis. And what do you see? These are all crater defects, almost 360 degrees around the implant. Yeah. So these are implants that were probably placed into good bone. And then the patients developed peri-implantitis, so you get the circumferential bone loss. Okay, so all right, maybe this is really peri-implantitis, except when you see this. You see the cement tag? And the cement tag, where is the cement on? It's on the implant surface. If the implant was in bone to start with, how does the cement get onto the implant surface? The bone was never there, right? It was never there when the prosthesis was cemented. So that probably went into an extraction socket or an early healing socket with the site where there was no bone. So sometimes we say, that's peri-implantitis. This can be iatrogenic as well. But let's say all of these cases, all the implants with perfect bone, and therefore we can argue that this is most likely peri-implantitis. Have a look at these cases. These cases are all the dehiscence defects with loss of the buccal bone, loss of the lingual bone. These are implants placed into narrow ridges. Implants placed into narrow ridges so that when they develop bone loss and then they develop a biofilm infection, it spreads around the implant, but you get this through and through defect. Buccal bone loss, lingual bone loss, buccal bone loss, palatal bone loss. Yes, this is peri-implantitis, but these are implants placed into narrow ridges. So next time you have a case of peri-implantitis, either a patient you treated yourself or that's referred to you, have a very close look at the bone morphology. And try to think, was this really peri-implantitis, or was it a failure of the treatment that was provided to the patient resulting in bone loss, and now it's ended up with peri-implant infection? Because I know we talk about, there's lots of peri-implantitis, people say there's an epidemic, but most of it, I firmly believe, and I don't have evidence for this, but I think the majority of these implant complications have an iatrogenic component. In other words, a dental-related issue with wrong decisions being made for the implants to be placed. Here is another clinician risk factor. Implant placed into extraction sockets. We spoke about that this morning, and we spoke about the fact that when an implant is placed into the socket, you're expecting the bone to heal. So first question you have to ask yourself is, when I take out a tooth and I come back 8 to 10 weeks later, do I always find bone filling in the socket? Or do I sometimes find a residual defect? Or I sometimes find granulation tissue that's still there? Sometimes it doesn't heal, sometimes it heals. We don't know, it's so variable. So this is a patient, I placed this implant as an immediate implant, developed infection, I go back in, it looks like a fresh extraction socket. This is the site where the regeneration failed to work. So I did the grafting, but it just did not work. And so we have a residual peri-implant defect. It's almost exactly the same as the day the implant went in. Here's another case referred to me. Please treat peri-implantitis. I open a flat, cemented crown, you can see the cement. You can also see a non-healed extraction socket. Okay? So we expect that when we place an implant into an extraction socket, it will fill with bone, but it doesn't always fill with bone. So we have to go back to the literature. Now these are older studies now. One of them is my study in 2007. And the reason we don't have too many of these studies I mentioned was it's very rare now to be able to do re-entries. It's very difficult to get ethics approved now for re-entry procedures. All these sites are grafted, internal grafting of the extraction sockets. And you see in the blue, complete fill, and you see in the orange, incomplete fill. How many percentage of the sites with incomplete fill? So the incomplete fill ranged from 10% in the David Gelb study down to 80% incomplete fill in the Wang study, Conley and Wang study, with one of these postgraduate students in 2007. Wow. So what's happening? We put implants in and we graft and we don't get filled, then we've got exposed implant surface in a high proportion of cases. And then when we get peri-implantitis 5 years later, we wonder why that happened. Oh my goodness, peri-implantitis. But maybe it was because the conditions were not right, that we ended up with bone loss. And then of course cement. So everybody says, do not cement your implants now because of the risk of peri-implantitis. And Tom Wilson published a paper very early on alerting us to that. So here we go, excess cement. But where is the cement? It's on the rough surface of the implant. Is that cement or is it because of a failure of the treatment? And then an uncleanable prosthesis. If the patient cannot clean, you cannot clean, nobody can clean it, you're going to run the risk of developing problems. And then we used to ask our patients to use superfloss to clean underneath. It resulted in a lot of floss being caught, tags, and developed peri-implant infection. So these are all things that are iatrogenic. Okay, so how do we treat this? I have a very simple approach to treatment of peri-implantitis. Peri-implantitis is a biofilm contamination on the implant surface. And when you have a biofilm contamination on the implant surface, to treat the infection, you have to remove the biofilm. Now, removal of the biofilm requires access to the affected surface. Sometimes we can do it closed, sometimes we have to open a flap, sometimes we have to take off the prosthesis, but you need access. And then, how easy it is to clean depends upon the implant surface itself. Whether it's a very rough surface, porous, or whether it's a micro-rough surface like an SLA. So different implant surfaces have different approaches to that. So the principle is simple. Disrupt and disperse the biofilm. And this requires mechanical disruption of some description. Whether it's a physical disruption with your hands, ultrasonics, air spray, or air powder sprays, or whatever, or titanium brushes, it doesn't matter. The main thing is that you have to disperse the biofilm, and you bring then the bacterial load down to a level that's low enough for then the body, the patient's natural immune system can then take over and decontaminate and remove the rest of the bacteria. So that's what you're after. So reduce the microbiological load. So let's look at a case of mucositis. So you see here a patient whose prosthesis has been in place for a couple of years, comes in, slightly increases probing pocket, bleeding after probing, and look carefully at the slight reduction in the radial density of the bone. It's not bone loss, but it's a reduction in bone density compared to previous radiographs. And that's because there is inflammation, and the inflammation is causing the bone mineral to be leached out. This is the start of peri-implantitis if you don't catch it. So what we do is we debride the sulcular region with floss, with titanium curettes, with erythritol air polishing devices, whatever you can and whatever works for you to clean the biofilm. In the closed way, no open flap, because it's still quite shallow. Then provide the patient with proper education on how to clean the area. You can sometimes use topical disinfectants like chlorhexidine gel. Right, so here's what we use, these mini titanium curettes around the implants. And here is some time later. Right, so the infection has resolved, and you can see the return in the radial density. So the x-rays will tell you if you've been successful. You'll see an increase in radial density around the implant. Okay, so it's successful treatment. And he's still in maintenance, right up to today. Comes in once a year only now, because he's very good oral hygiene to do a checkup. I think that one of the big advances in monitoring maintenance has been these powder, compressed air, water jets. This is EMS, airflow, the airflow plus. Because these, if directed carefully around implant reconstruction, can go down into the pocket several millimeters. And it avoids having to use metallic instruments to try and clean around some very difficult reconstructions. So we bought one. This is great. Then the hygienist wanted one. And then we started with there's myself and my 2 other partners. And then we had 3 hygienists. Everybody's fighting for it. In the end, we have 6 now. Because we're using them all the time. All the time, not just for our implant patients, but patients who have extensive crown and bridge work, cleaning with gentle powder spray around crown margins. It's a perfect way to clean around fillings, cervical fillings, around dental implants, and fix tooth prosthesis. So this I strongly recommend this to you. So that was mucositis. So peri-implantitis. So it's depending upon the extent of the bone loss, if you choose to treat it or not. And that's a very subjective decision. So what are the principles? Access for removal of biofilm. That's the only thing you have to think about. And if you can get access without opening a flap, fine. If you cannot, you have to open a flap, or you might have to remove the prosthesis. Here we have a tooth to implant prosthesis, cemented. So there's no way I can take the prosthesis out. We have to treat this with the prosthesis position. So the treatment of early peri-implantitis, oral hygiene education, if necessary, modify the prosthesis to make it more clinical. Local debridement under local anesthesia with titanium curettes, with air powder cleaning. Sometimes we think about systemic antibiotics. I'll only consider that if I see suppuration, and then the topical chlorhexidine gels as a follow-up to manage this. And most mild peri-implantitis can be managed. With moderately advanced peri-implantitis, then I think you need surgical access, because just getting to the surface is very difficult, especially around the threads and so on. And if it's very advanced, then implant removal is probably the way to go. Now, this is a paper that was published in 2016 by Lisa Heights-Mayfield. I think Lisa's probably all known to you. She's a periodontist who was in Europe for many years. Now she's back in Perth. She's also the editor-in-chief of Clinical Oral Implants Research, a very powerful position because she says what can be published and what cannot be published. So this was a multi-center study. I contributed a couple of patients to this. Multi-center study, 36 implants in 24 patients, all treated with open flap debridement, adjunctive systemic antibiotics, combination of amoxicillin, metronidazole. Then importantly, daily chlorhexidine rinses for 4 weeks. And then supportive therapy for the first 12 months on a 3-monthly basis. And then the patients went back to the referring practitioners and came back 5 years later. So the patient-based data of the 24 patients, 4 of these patients in the gray were lost to follow-up, so they didn't come back, so they left 20 patients. 15 of the patients, so 63% had success, no recurrence in the disease. So almost 2/3 of the patients had no recurrent peri-implantitis. I mean, that's a good news story, isn't it? 5 years, no recurrence. Of course, there were some that had recurrence in the disease. And if we look at this on an implant basis, there were 36 implants in these 24 patients. Of course, 4 patients didn't come back for follow-up, meaning that equated to 8 implants that didn't come back. So leaving behind the remaining implants. So you can see on an implant basis, there was success in 19 of these implants, or 53%. So when I see a patient with peri-implantitis that's not advancing, early to moderately advanced peri-implantitis, I say to them, if I treat you, you have about a 50% chance of, as long as you do all the right things, a 50% chance of retaining this implant and without recurrence over a 3 to 5 year period. I try and be a bit conservative. If you have a recurrence in the disease, you then have to make a big decision. Do you keep retreating it, or do you make a decision, it's time to take the implant out? So I will attempt treatment once, but I generally don't like surgical treatment second time, third time, fourth time. It's pointless if it's going to become continuously reinfected. So What does the surgery involve? So this is August 2007. This is a patient that I placed an immediate implant on. All right, so there's the periapical radiograph, and there's the periodontal probe into the pocket, going all the way up to the apex. So there's the non-healing of the extraction socket. So this is one of these immediate implants placed without any grafting, because the jumping gap was supposed to fill with bone, but it didn't always fill, as we discussed. So this is an SLA implant, and the SLA surface is probably, for me, the most, not easiest, but it's the surface that will respond most positively to the treatment of peri-implantitis, because it's a micro rough surface, and this is a tissue level implant. So what do? I open up a flap, I remove the granulation tissue. If I see calculus, I remove the calculus, with titanium hand instrument. If I have to use an ultrasonic scaler, I will use an ultrasonic scaler, even if it roughens that surface. I then disinfect the area with 3% hydrogen peroxide, alternating with sterile saline, and then I'll use a titanium curette to carefully debride continuously, washing with saline. Wash, wash, wash. So the idea is physical dispersion, and diluting down the bacteria. So the microbiologists will tell you, dilute down the bacteria, so that eventually what's left, the body can take care of. I do no implantoplasty. I don't smoothen the implants, I don't take threads off, and I don't graft the sites. Because the grafting will not work if you leave biofilm behind. It just gets reinfected, and it then becomes a very expensive exercise. Plus the fact that you take an X-ray, you never really know what's going on with the site. Right? So I treat it non-surgically. So there you go, granulation tissue, hydrogen peroxide, surface contamination, and 2 weeks of chlorhexidine rinses, and then I follow up myself. I extend what Lisa did in her study. It was 6 weeks of chlorhexidine gel to be applied twice a day. Because what you want is healing to take place, soft tissue attachment without bacterial contamination into the site. So it's an anti-infective approach. So it's not just the surgery, but it's the follow-up, which is important. And when I changed my protocol to this, I found I got much, much better results because we've adopted an anti-infective approach. And today, the systemic antibiotics are generally used to be azithromycin. It's easier for the patients to take compared to the amoxicillin metronidazole combination. Okay? And so this is 6 months, 1 year, and 4 years later. Okay, so this patient I still see today. This is 20 years later, she's still coming in to see me, everything is stable. This is 4 years after treatment. That's the post-treatment 4-year radiograph, and this was the original radiograph. So when you don't graft, you should be able to see the regeneration of the bone and a recorticalization of the bone. A new cortical layer starts to form. When you see that, you know you've got the infection under control. That's why I don't like to graft these sites, because it's very hard to see if you've grafted it. Without a graft, you can see very clearly what's happening to the marginal bone area. So it's another patient who's referred to me with active periodontal disease, untreated, also with peri-implantitis on these implants. Okay, so you can see the distal implant seems to be free of infection. The anterior implant has got suppuration. If you look here, you'll see the distal implant already has bone loss to the second thread. And here we have the bone loss all the way down in active infection. And when I open up a flap, you can see the reason this marginal bone has disappeared. These are big implants, wide implants placed into a narrow ridge. And in a periodontal patient. Lucky the back implant didn't develop peri-implantitis. It's the one in the front that developed peri-implantitis. These externally hexed implants. This is a Talienite surface Nobel implant, which is a fairly rough surface. So before this, the patient receives periodontal therapy. Then we do local debridement as part of the periodontal therapy, and then surgical access to the definitive treatment. Okay, so the same protocol, remove granulation tissue, decontaminate, hydrogen peroxide, followed by physical dispersion with titanium curettes. Of course, you can use the titanium brushes, there's the galval surge now, anything works, as long as you remove biofilm. That's the basic principle. So this is 3 months post-op, 3 months post-operative control. You see a little bit of bone regeneration, and 1 year post-operative control. It's now starting to fill in with some bone spontaneously, and a recorticalization of the site. There's a change. Right? Now this patient now has been 8 years in maintenance now. No recurrence of the disease. No recurrence of the disease. He comes in twice a year and we flush it out with the airflow. Right? And he continues to apply a disinfectant once or twice a year. So you can treat peri-implantitis. It can be treated, and certainly it's worth treating at least once. If this kept recurring, we'd be talking about taking the implant out and starting again. I show you this case because we all have to show you our most traumatic cases. So this is the case in September 2008. This is the implant here. This one, developed peri-implantitis. That's the opening of the flap. This is an SLA implant, tissue level implant. Same debridement, no bone grafting. 2008, you can see the bone loss. 2010, 2014, grown bone. Look at that. This is the one and only case that has grown bone like that. But if you think about it, that implant's in the bone walls. It's still completely within bone walls. It just developed an infection. So the body can heal itself and bone can regenerate. I don't know whether there's bone on the outside, but certainly in the proximal area on the palatal side, it's looking really good. No recurrence. He's still coming in for his maintenance after 15 years. No recurrence of the peri-implantitis. SLA surface. It's definitely a surface that's conducive, and also the tissue level implant design. Now, I think Dr. Lam, you mentioned is the tissue level implant takes the restorative margin away from the bone level. I think that makes a big difference. So the consensus from the last ITI consensus conference is that you can expect 3/4 of the implants if you treat them to be there after 5 years. So I think if you're thinking about extending the life of a prosthesis and implant, it's worth at least treating once. And sometimes your patients will respond really well. That's great. The ones that don't respond well and you have a recurrence, then I sit down and have a very hard discussion with them about, I think it's time to take the implant out and think about other treatment strategies. So this is the case where I've treated it once. We've had 8 years of maintenance, and then eventually it's progression. This patient now I'm actually seeing next month because we're converting her to a full arch. She has some posterior implants. We're taking out some other teeth and giving her a full arch of processor implants, adding 2 more implants and converting her to a fixed, fully fixed intermediate loading. Okay, so we have ongoing contingencies for this patient. So here I always like to show this 2 tissue level implants. One without bone loss, one with bone loss. What's the difference between the 2? The bone was thinner on one than the other one. That's what happened. Yeah, that's what happened. And then slowly it got contaminated. She's a periodontal patient, so she gets infected. She's a smoker as well, she doesn't help. So this increases her risks. All right, so strategies to minimize the risk. So in practical terms, how do I approach these patients? The periodontal patients I'm talking about now. I take a low-risk approach. So this is a patient referred to me. She's actually a Vietnamese lady. She migrated to Australia many years ago. At this stage, she was 44 years of age, and a regular dental attendant because she was scared of dentists. Medical history was really not remarkable, and the medication she was just on standards. But she had significant gum disease. Just the periodontal charting, you don't have to see this, but to show you the radiographs. Or also advanced disease. Now, do I plan for implants in this patient? Absolutely not. I do not know if this patient is compliant. I have no idea if she's going to respond to therapy. I have no idea if she's going to come back for recalls and maintenance. So I cannot make this decision. So I say to them, because she came in for implants, I said, well, no, you're not getting implants. If you want me to treat you, then you have to allow me to treat you properly. It means even though some teeth are coming out, we're treating you first for your gum disease. And only in time, when we get a sense and a feel for how your tissues respond, how compliant you are, then we can think about treatment options for you. Because it could be a denture. It could be a denture with 1 or 2 implants for retention, or it could be a full implant prosthesis. Okay? So, consensus statements from Group 5 in the 2018 Consensus Conference. I follow these recommendations. This is how I treat these patients. Number 1, completion of active periodontal therapy should precede any consideration of implant therapy. All right? You need to do this first. Treat the patient. Take teeth out that cannot be treated. Treat teeth that are irrational to treat. Don't hold on to them. Get the patient used to the idea that they're going to have to wear some sort of removal or prosthesis. It's pretty hard and harsh, but sometimes you need to do this. So we take these teeth out and leave the ones that have a reasonable foundation. Provide that treatment. Because sometimes these teeth can be retained, and we don't have to take out all the teeth. Keeping some teeth is very appropriate section. Eliminate the residual pockets. If you can't eliminate the pockets by treatment, then we do it surgically. If you can't do it surgically because of occasions, we need to think about removing those teeth, because they are reservoirs of bacteria which can affect the teeth and affect the implant. You want a plaque score of less than 10%. Compliance. Patient needs to prove to you that they're compliant. Now this is the periodontist talking, not the implantologist. Yeah? So these are rules that I do not break. Time and patience is required to manage these patients. If they want the implants tomorrow, they have to go somewhere else. I'm not interested in treating them. They need to buy in to the principles of sound therapy. So you need time and patience to achieve the goals of the cause-related phase, which I just established for you. And compliance. Compliance is the most important thing. This patient's going to come back to compliance. And this is not the same case, another case. So remember that your initial phase therapy is part of the diagnostic phase of treatment. So I say to the patients, we are giving you some treatment to see if your tissues respond and if you're going to be a good responder. Because if you're a good responder, we can think about other sorts of treatment down the track. You do this with crown and bridge. You have someone in with a broken bridge or extensive. You say, I have to give you some treatment. I've got to pull off the prosthesis. I have to take out the fillings. I have to do some treatment to see what's going on underneath before I can make some decisions. Yeah. So we do that restoratively, and the same principles with periimplantitis. The patient's a responder. So now, guess what? We're not taking out those lower front teeth. We're keeping those teeth because the patient is responding. So refer for implants, full lower implants, full arch, has now become a patient who's compliant, who now becomes a periodontal maintenance patient. Maybe in 10 years' time we might have to think about it, but it's no longer a massive treatment. So you have to understand that your initial treatment is actually part of the diagnosis for the patient. And here is the risk factors, as I said, for periodontitis. So I've already showed you this later on. Now this study on the right-hand side came out of Brisbane. A good colleague of mine in the early 90s, Ken Nixon, is retired now, a peridontist. He did an analysis in his practice of the patients that came in for periodontal treatment, how many came back for maintenance. And you can see the dropout rate after 1 year. 40% dropped out after the first year. And by the time they got to the 50th, 60% of patients had dropped out. So if you're trying to establish compliance and trying to establish that the patients will come back in a recall, you cannot do this in a short space of time. So periodontal patients who come in wanting implants, on average, is 18 months to 2 years before we even talk about implants at that stage. Dr. Ram, I have a case that we're going to show at the World Symposium next year. We've video recorded it. So we've given her full upper implants, on TLX implants actually, which has been a patient of mine for 6 years. Periodontal patient for 6 years. And it's only after 6 years we reached the stage where we said, yep, she stopped smoking a year ago, she's lost the front tooth, and now it's time to have the implant. But I know this patient because they've been in the practice for a long time, and I know she is compliant, although she lives 60 kilometers away to come in for treatment 3 times a year. So you know the level of commitment. Then in choosing your implants, choose an implant without an interface at bone level. My periodontal patients receive tissue-level implants, except in the upper anterior region, if you want to hide the margins. By and large, they get tissue-level implant. I don't care if the metal margins are showing. Nobody sees it, but it's accessible for maintenance further down the track. And Dr. Lam showed you this study, Jan Dirks, that showed that in the Swedish registry Okay, of 598 patients with at least implants in from at least 9 years, all the patients at 9 years, there was moderate to severe periodontitis at 14.5% based on their diagnostic criteria. And when they looked at the different implant systems, the three major, and don't forget these are implants provided by the Swedish social system. Patients get their implants for free in Sweden. And therefore there is a register, a reporting register. As a surgeon, you must report complications. So all the complications, the Straumann tissue level implant with the SLA says have the lowest incidence of periimplantitis, 0.5%. And when you do the odds ratio analysis, you take the tissue level implant as the reference implant, and then compare all the others against the reference implant. And you can see the other two brands, the odds ratios are almost 3.5 to 4 times greater than the Straumann tissue level implant with the SLA cells. So these are not bone level implants, these are only tissue level implants. And the combination of the other systems, other brands in the market were worse off. Still relatively low, 5% over 9 years. But it shows you clearly the evidence is so strong for the tissue level implant. So this is the only implant that I will use in periodontal patients. Just putting the posterior. Oh, I was just saying, and also remember that these implants are treatable. So this is the case I showed you, the tooth implant bridge. The periimplantitis is treated. I close the divider, and you get a response. If using bone level implants in periodontal patients, move the interface away from the bone level, the restorative interface. Right? Have it close to the surface so you can access it. Right? So move that platform to an equimucosal or a supramucosal position. At least 1.5 millimeters between the restorative margin and the bone. We know anything less than that increases the risk of periimplantitis. Okay, so here we have to think about interfaces now, where this interface might be in our periodontal patients. In fact, we should be looking at it for all our patients. Retain cement tags, so we avoid cemented prosthesis. Avoid implants that are too close together, obvious reasons. Design the prosthesis to be cleanable. Inaccessibility for home care increases the risk of periimplantitis. There's a 65% predicted value. Okay, so that's how you design your prosthesis. And look for short spans. So this is the same patient I started off showing you. We look for short span prosthesis. Cantilevers wherever you can do cantilevers. Yeah. Keep things separate. If this was a full arch, I would also segment full arch. And separate implants. Don't have implants next to each other. Right? So this improves hygiene, it improves access to maintenance, and also gives you retrievability. France's paper in 2009 showed that when you have multiple implants, the end implants were at least risk. The middle implants, if they're all joined together, had greater risk of periimplantitis. So it makes sense. Try and make everything an end implant, which means 2 implants in the bridge. Then both implants are at the end. You have a third implant, and that implant's in the middle. If you're going to do that, make sure you're separating them far apart so that there's access for cleaning and access for maintenance. But ideally, short spans, and create everything as an end abutment. Okay? So this is not the situation that you want to have, where you have multiple implants adjacent or split together. And in a periodontal patient, it's suicide. It increases the risk of periimplantitis. So this is not what you want. Also, you don't have to replace every tooth. Periodontal patients often have a reduced chewing capacity because their teeth were loose for a long time. So sometimes we only look at replacing up to the premolars. So premolar occlusion, shortened dental arch. You don't even have to replace the first molars. And in the upper, you can cantilever if you've got no lower teeth. You can cantilever to the molars just for aesthetics. Right? So you can do that and satisfy the patient's aesthetic needs. So we adopted this approach in our periodontal patients very frequently. Shortened dental arch. We don't have to replace every tooth that's gone missing. And utilize, where possible, conventional prosthodontics. I don't know whether any of you have seen this. There is a resin bonded bridge here. This is a relatively short span, so we had a resin bonded bridge to replace that. Okay, so, and it's a relatively small gap. I could squeeze in a narrow implant here, then it gets too close to the teeth, not cleanable. then we start to increase risk. So we kept it simple, use conventional tooth-related prosthodontics. Right, so here you have the patient finally completed. It took 2.5 years to get to this stage with her in active treatment. And then finally, she still has trouble cleaning the prosthesis, so she has to be in a supportive maintenance program to ensure that we reduce the risk of periimplantitis. Okay, so I will conclude by saying that we must recognize the patient and clinician-related risk factors for periimplantitis. And if we think about the complication model of periimplantitis as opposed to the disease model, then we start to think about what is it that I have done to create or to result in this complication. Because it's now no longer completely attributable to the patient. And those patients with a history of periodontitis are particularly at risk. We know this. So we have to do whatever is necessary to try and reduce that risk. But at the same time, they are the most needy of our patients because they lose teeth through a disease process that has a high genetic susceptibility. And they lose teeth, they lose their confidence, if it's front teeth, their social, their welfare, their esteem, their psychological health, mental health. So it's very, very powerful reasons why we need to help this group of patients whenever we can. And so that we need to understand the risk factors for the biological complications for this patient. And finally, develop treatment and maintenance strategies to reduce the risk of complications. And remember that as a clinician, we are the ones who are responsible for making all the decisions for our patients. So we need to think about this before we prescribe the treatment. Okay, thank you very much.
Thank you so much, Dr. Stephen Chen. And as we